Dr. Basu, you want to go ahead and get started? Dr. Basu here.
Yes, so shall we get started, sir? I'll just start the session if that's fine.
I think we can go ahead, right? Dr. Basu, you are muted, so yeah.
Oh, no, I'm here.
Okay, good.
Good,
Awesome.
good. Yeah. So go ahead, Dr. Garg.
Yeah, so good evening, good morning, and good afternoon to everyone joining us from different parts of the world. I am Dr. Aditi Garg. I'm your moderator for today's very important and timely webinar presented by API, Crack the Code for Residency in the US, the critical need of research to match in residency for IMGs. And this webinar is dedicated to all international medical graduates who are dreaming of matching into US residency programs. And today, let's understand why research is very important in this. We are honored to be joined by two exceptional leaders from the field of medicine and medical advocacy, both of whom have walked the path many of you are on today. So they have experienced it firsthand, and now let's listen from them, let's hear from them why research is important and how we can get into residency. So this is my privilege to introduce Dr. Satish Katula. Most of you might know him already. He is a hematologist and an oncologist and currently serving as the president of API. He's just not a respected physician, but also a passionate advocate for medical education and IMG support. Given his book on immigrant doctors chasing the big American dream, he has explained much of it in the book. And today, let's understand from him. He brings with him the wealth of insights into how IMGs can navigate the complex US medical system. So let's welcome Dr. Katula and please, sir,
Thank
over
you,
to you.
Aditi, for that kind introduction. My name is Dr. Satish Katula. As Aditi mentioned, I'm the current president of AAPI. I'm a clinical professor at Wright State University, mostly clinical, some academic, but I've been working in Dayton, Ohio for the last 29 years. And I was an IMG, International Medical Graduate. So I was like one of you. So was Dr. Basurai 35 years ago. So we all went through the same path. It's not easy, and it's getting tougher every time. It used to be like people used to get green cards, to come to this country about 3-4 decades ago, and they would send a limo to the airports to pick up the doctors. Gone are those days, and it's getting tougher and tougher now with visa situation. It has become very difficult, and a lot of J1 visa holders, who cannot actually come at this time if they did not already get interview, even though they got a position here. So there are multiple things that IMGs go through. It's just not the scores or not the credentials that they are supposed to get, or the getting into medical residency is a tough thing nowadays. So we're trying to help every which way we can, and how you can make your application better, being IMGs or even US medical graduates. Research is a very important component. Nowadays USMLE has no score on step one. Step two, everybody's getting good scores. And what is other demarcation for people who are applying, especially IMGs who are coming from different countries, especially India? So how we can actually make their application better. So we are trying to do some mentorship programs. We have done one for high school students and pre-med students, and then we did one for the medical students and IMGs who are actually trying to get into residencies. And part of that was research, but that was only a small part that we talked about in the last webinar. But now we want to focus mostly on research, because everybody's looking for research. It's not that easy to find. And I did a survey of IMGs recently, and most of them found that finding a mentor is the most difficult thing in the US. And how we can make that happen for a lot of you. It's not an easy thing, as I said. And if you go to smaller cities or community programs, there is no research. And the program I work in has very few opportunities for research. So you have to be in a big place, like, big university places, academic centers to actually get some research. And nowadays, there is a lot of competition for research, not only the IMGs, but also not only the medical students who are trying to get into residencies, but people who are in high school, even they are trying to get into research. Like at the age of 16, they are barely 16 or 17, they want to do some research to get into medical school. So there's a lot of competition for research from high school students to pre-med students to medical students to residents who are actually in residency but wanting to get into fellowships. So everybody needs research, and research is the way we innovate things. And a lot of people that should be part of our career as physicians, because physicians are scientists, because we actually do everything scientifically, right? So if we really have to give a treatment, we base that treatment on evidence. Where is the evidence? That is done by the research. The evidence come from the research. So research is part of our careers. It's not like working for other fields, for example, IT or whichever. I mean, they probably don't need as much research, but for medicine, there's a lot of innovation. The innovation keeps happening, and how do we really keep ourselves, in the forefront in that? So that's why even if you don't get into research, you can write case reports, you can write literature reviews, you can do a lot of other things, which Dr. Basu will talk about. So that's why it's very, very important. And when me and Dr. Basu met in a conference, we thought it's a very good thing for medical students and IMGs to get into this research and do some studies. At least they can, get familiar with how the research works and how they can contribute to the medicine. By doing so, you can also make your application better. So it's a win-win situation, and that's why we thought of conducting a webinar for international medical graduates and medical students from the U.S. So, Dr. Basure has wealth of knowledge, and he has been a professor. He's a cardiologist, electrophysiologist, working in Tampa, no, actually Memphis, Tennessee. He's a very accomplished physician. He's an author too. He wrote a few books, and he's the president of Indo-American Press Club, and he has a lot of feathers in his cap. So I will let Aditi Garg introduce Dr. Basure, who will enlighten us about research and experience. Thank you.
Thank you so much, Dr. Katula, for those empowering insights. So up next, we have our speaker whose work lies in the intersection of medicine, spirituality, and global health. We have Dr. Indranil Basure, who is a renowned cardiologist and interventional cardiac electrophysiologist, and someone deeply involved in academic mentorship and research guidance for IMGs already. He'll walk us through today on the critical role of research and how it can significantly strengthen your math journey. So let's welcome over to you, Dr. Basure.
Thank you very much, Aditi and Dr. Katula, for those nice words about me. I'm not sure if I really worth all that, but long story short, let's try to dive in, get people the actual picture. Why it has become tough to get into residency. To be very honest with you, it's actually not got more tough. It has got little more technical. And once you know the secrets, you will get it. Because don't forget, America by 10, 20, 35 needs 10,000 foreign doctors. So there are hundreds of seats for there, but you need to be the right person at the right time. And that's what we are going to talk today. So let me share my screen, and then we'll go ahead.
So Aditi, is there a possibility of recording this Zoom meeting?
Yes, definitely.
Yeah, let's do that, because the people who cannot attend today maybe watch it later. So.
Okay, guys, can you see my screen?
Yes.
Okay, perfect. So So this is the story with getting into residency. Getting into residency has got tougher by every year. The entire last decade, and I'll show you some slide to actually prove what Dr. Katula just said, that people used to get green card and limousine is to be sent to the airport. I'll tell you why that was true and what's the scenario now. So matching started in around 1958. And since then, last 10 years, we had only 11,000, 12,000 people applying. The maximum was 17,000. Last year, there's over 23,000 people applied. This year, 24-25 match, 50,000 people applied. And this is not my statistics. As you can see, all these statistics are from the National NRMP Residency Match website. So that's the body which most of you know actually conducts the matching. So this is the reason why people got green card and was sent limousine in the airport, because there were thousands of seats open, which is the yellow color, and there were not enough people. So if you desired to leave India, take the trouble, come all the way to America, America was with open hands welcoming you. But of course, the scenes changed, and it changed drastically from around 2000. You can see there's a huge gap. And this is around this time when me and Dr. Katula got into medicine here. The gap is almost same since then, maybe slightly decreased because last couple of years, there has been few medical programs that has been added, but not many. So though this looks that the gap, as you can see, the gap was much huge in the entire 2000, but the advantage at that time was the competition was less. But this year, as you know, the gap is almost the same, but the competition is 4 times more with over 50,000 people applying. So who are these people who don't get it? So if you look at, this is a very busy slide. Don't bother to look at everything. Look at here, percentage of active applicant who match to PG1 position, that is the who successfully matched. The number has gone down by 0.4%. You don't have to look at anything else. All the rest of the screen shows all the different determinants. That is USMD seniors, USMDO seniors. MD seniors is basically people who completed their medical school and who are MDs. In America, I don't know, a lot of you are from India. There are 2 types of medical degrees. There is MD and there is DO. So there are obviously way more MD schools. And most of the top academic schools are all MD. They give MD as the degree. So MD at the degree is equivalent to MBBS in India. So it's MD degree you get. But there are a couple of schools which have DO, and so that's what is being shown here. Let's go to the next page. And if you look at the US IMG, that is IMGs trained outside but US citizens, there's really been much of decrease. Actually, the number increased. There's a 0.8% increase. So who are the group that got maximum hit in this match? And here is the answer. Percentage of non-US IMGs who matched was down by 0.5%. That's a huge number, considering the fact there were 50,000 applications. So let's understand what changed from what was there before to now, so that we understand what is the secret behind this. How can we crack that code? And let's see what needs to be done. So this is a trace for the last couple of years from 2021, that's the COVID year till now. If you look carefully, the numbers have technically increased, but really it's a flat curve. So for most IMGs, the curve has been flat because certain changes happened from 2022, and we'll talk about that just now. And a lot of IMGs are completely ignorant of that changes because they don't live in America, they live in India. So they have no clue what is going on in the medical system here. And that has caught a lot of people unaware. And despite people applying, having a brilliant medical career in India, and wanting to come to the US, they're not getting in. So what is the catch? Let's find that out. This is a curve again from NRMP. None of these are my graphs, my thought process. These are all directly from the headquarters of matching, NRMP. If you look, this is a complicated place. I'll just drive you through the whole place. Go through the lowest curve, which is in orange. And if you see carefully, that is the number of position per applicant. And that doesn't discern between US, India, doesn't matter. Total applicants has been almost the same. Why? Because America, the government of America is adverse to opening more colleges or allowing more programs randomly. They don't want colleges and schools and universities to mushroom or hospitals to mushroom, give training without having proper guidance, without following proper rules. So from 2016 to 2025, the whole decade, it's a straight line. So that has an advantage and that has a disadvantage also, and I'll just come to that. But look at the curve above that, which is it's in violet or pink or whatever you want to call it, but certainly not in blue or green. Look at the curve. That's the curve for foreign medical graduates who are non-US citizen, but foreign medical graduates. You see the curve, there's a massive dip in the curve, and the dip started from 2022, and I'll talk about that again, why 2022 is the landmark year. And that has been a substantial dip. Now, if you look at the US seniors, people who graduated from US medical school, see the position, there's a huge jump. So for per position, they have more, per applicant, they have more positions. So they are at an advantage. Whatever happened after 2022 gave US graduates an advantage. So today, almost 98% of graduates get it. Between 95 to 98% of US graduates get it. Now, there has been a dip, so-called dip, really not a dip with DO, but that is sort of not a real true dip. That dip is because there are more MDs getting into residencies compared to DO for different reasons. One of the reasons is that there are less DO schools also. And a lot of MD schools have, as I said, all the top academic institutions in the country, all the top university in each state. They are highly academic. Their students get a preference, even among American citizens and American graduates. So this is not really showing what the true picture is. But long story short, whereas there is increase in the number of positions for that Americans have got, there's actually been a substantial decrease in IMGs. So let's see what the story is out there. So this is what happened in 2022. In 2022, USMLE Step 1 has stopped becoming, you used to get a 3-figure result of what your numeric score was. From 2022, there was no numeric score for USMLE 1. So USMLE 1, you're either P, that is pass, or you're F, or you failed. If you failed, you can give the exam again. And if you passed, of course, you are done. But remember, if you passed, you might have got 70 marks more than me. But I have also passed, Dr. Katula also passed, you also passed. There's no way to differentiate between you and any one of us. And that's a big problem, and I'll show you why. In our time, we didn't have this. We had USMLE 1 and step marks played a role. So what did this do? From 2022, as you saw, they stopped CS, the USMLE 1 stopped having a score. So as a result of that, there was increased emphasis on step 2. So step 2 became the primary standardized metric. That's the word we use in USMLE. It's a US term. That's the primary metric for residency program. So your USMLE score will decide how good you are, because USMLE 1 has got no score. So to perform, you have to have a strong CK or CS score in USMLE 2, only then you will get it. But there is a catch in that, and I'll talk to that later on. Second is this, and this is very, very important for all foreign medical graduates. One, program started placing more weights on clinical grade and clerkship performance. What is that? That sounds Japanese to most of you. Yes, because none of you have gone through those. That's typically for an American graduate. So you have to understand this very clearly. An American graduate has to get a letter from the dean, from the head of the department. You have to get 3 letters. So out of the 3 letters, one of the letters should be your dean, one of the letters should be your head of department. Suppose you're applying in dermatology, chief of dermatology, medicine, chief of medicine, family medicine, chief of family medicine. So they don't write a letter saying, oh, Dr. XYZ is the world's best doctor I've seen in my life. Nothing, none of those adjectives take place there. It's a very well-defined template where they talk about your clinical skills, how you marks you much got in your clerkship, how was your behavior with other of your peer, how was your behavior with patients, your clinic, your bedside behavior, all these things comes. So you have to understand that that has become very important. But I can, as a program director in America, I have no clue about you, because all that you have is 3 letters of for the NRMP, and these letters come from either a research letter, which somebody like me provides, and I'll talk a little bit about that, or observership letter. And both letters are not same. The observership letter, you observe for 1 month, 2 months, 3 months, that's it. So I have no clue that as a program director, what you are. So you are basically all foreign medical graduates, unfortunately, start as a black box. I am taking you as a clinical person, but your clinical ability is a black box to me, whereas that's not true for American graduates. And that's what, unfortunately, the scenario has become. So how do you make up? So what the program director does is he uses research to see if you are clinically competent. And I'll show you why they do that. That's based on a lot of research. It's not artificial, it's not arbitrary, it is not what the program director thinks by themselves. No. Everything in America is well planned, strategized based on trials. So, and I'll show you some of the actual papers. So research experience goes, as Dr. Katula said, that research and medicine goes together, and they are the twin, that they're entangled with each other. Unlike a lot of countries where clinical medicine has nothing to do with research, everything in medicine in America is intertwined with each other, and that's what it's important to have a research experience, and I'll talk about that. Second is a letter of recommendation. What is the difference between the letter of recommendation that you guys get from an observership and the letter from a research mentor like me? And then there are tons of other research mentors who help you, and from them. And of course, last is your extracurricular activities and leadership roles, especially top academic places like Harvard, Stanford. The quality of people they get is extremely good. So their typically marks or research letters doesn't matter, because most of them has 10, 15 publications when they win apply for medical school. So for them, it's very important to show your volunteer activities. You worked somewhere, you did free service, you did this, you did that. And how was your leadership role? Did you have peer interaction? And research also actually helped us to understand your leadership role also, and I'll talk a little bit about that. So this is the unfortunate part, that despite CS2 becoming an important primary metric, its importance have gone down. Why? In the past few years, there are tons of students, there are thousands of students getting over 250. 250 is sort of the break-even point, that if you don't get 250, they are not going to consider your, though there are exceptions. If you have extensive research, the 250 mark can be broken. Even without 250, you'll still get in if you have good research. So research is the most important thing. But other than that, you have to get 250. But last couple of years, 250, 260, it's huge number. I mean, thousands have been getting it. Like, I'll give you one example of a program. I cannot name you the program. I cannot name you the lady who's the program director, but she was my intern when I was a cardiology fellow. She tells me, Dr. Basure, for 4 seats, it's a community program, 4 seats, I had 2,800 applications, just 4 seats. So the rule of the thumb is, for application, you generally get 10 times the number. So she needed to get 40 people. How can you get 40 people? So she decided that will follow strictly the 250 number and make sure that only people above 250 she's going to call for interview. And she ended up finding 800 people out of the 2,800 or 700 something with more than 250. So she said, hey, what should I do? Then she said, okay, let me get people only with research. So she finally, she ended up having 70, 80 people, which was more than what she wanted, what she anticipated. And she was forced to take those interviews. Because remember, whatever plan you have, that plan has to be clearly written down, because these are put under microscope. And if it goes under microscope, people want to see that you really made a decision without favoring anybody. So, and that's how she ended up getting 70 people, which she didn't want. She wanted 40, 50 people, because interviewing takes a lot of time. And remember, these are physicians who have clinical duties, they have research duties, plus they're running an entire program. So they're extremely busy physicians. So they don't want to waste time interviewing extra people who they know they're not going to take. So residency has completely changed from 2022. For residency now, you have to give step 1 and you have to pass in that. So don't break your brain trying to get a high score in step 1, not worth it. Step 2, you need to get a good score, 250. Unfortunately, thousands are getting it, so it should be easy for you to get 250. But that will not get you leave alone a match, that will not get you an interview because there are thousands like you. There's nobody to decide who's better than the other. There's no way to decide who's better than the other. So the only way to decide is getting research. And here is the number from NRMP. A dermatology applicant who are US graduates, I'm not talking about IMG, has to get at least 21 publications to match into a dermatology program. So that's not a joke. That is the truth. If you want to see the figure, go type NRMP in your Google, go to NRMP site, you'll get all these numbers. None of these numbers have been cooked by us. They're all from the NRMP website. So it's important to know that what is the difference between people come and tell me, oh, sir, I got 3 research I did in XYZ, some top academic place, and I got 3 very good observership letter. Still, I didn't get an interview. Why? This is the reason. There's a big difference between a research letter and an observer. LOR stands for letter of recommendation. So the letter that is given by somebody who does research with me is called a research LOR. And when you do an observership, a lot of people pay a ton of money, $5,000, $2,500 to get observership letter. Are they important? Yes. They are only important to get you to match, but they are not important as far as getting you an interview or getting you to match. They're just important. They're the door that allows you to apply for matching. That's it. And why is it so? This is the reason. So research LOR, remember, is based on your work in the research setting. And it focuses on your analytical skills, your scientific thinking, your ability to work in a team and contribute to research. Whereas observership is based on your participation in observership, where you're basically shadowing a physician. And you do not have direct patient responsibility. Why? Because you cannot. You're not a registered physician in America. You do not have a license. So you cannot touch a patient. So even if in my private clinic, I allow you to touch a patient, which is actually illegal, I cannot write it in my letter. So none of my letter will tell you that Dr. X, Y, and Z worked in my lab, actually saw patient, triaged the patient, did the workup, and I found him to be a very good physician. I cannot say that if you're doing observership with me. So whereas because you're doing a research with me or a researcher mentor like me, they will write your analytical skill was good, your scientific thinking was appropriate. You are able to work with the team. A research works, 10 to 15 people work on one paper. So your ability to work on a team. What if this guy, you're taken for clinical medicine and the next day the program director finds out you're fighting with your other residents or you're fighting with your other cohorts, then what happens? He's in trouble. So that's why it's very important that he needs to have an understanding of each and one of these and how research helps, that we'll see shortly. So what does LOR from observership gives you? It just emphasizes your professionalism, that you're not fighting with other people, your eagerness to learn. That too, that's a questionable thing because in 1 month you can show them that you're super eager. Rest of your life you may not be eager at all. Technically, they believe that will help you understand the healthcare system, though that may or may not be true because after 25 years, I've still not understood the healthcare system, but because it's much more complex than that. But at least you have a orientation to American healthcare system, EMR, and that's the importance of this letter. Second, the recommender can only comment on your observational skills, not your clinical skills. He can comment on your punctuality, and perhaps you might be asking him questions and he might try to answer those and say, okay, this guy was asking me a lot of questions. That does not mean, and since you didn't touch any patient, he cannot write on your hands-on clinical task because you didn't do any one of them. You are not licensed to do that in the US. So that's very important to understand. So in summary, observership letter, 3 letters you need. You need observership letters to show that you have a basic understanding of the healthcare system, but that does not show you how good or bad a clinician you are. Neither it shows you whether you have any analytical skill, any scientific thinking, if you're able to work in a team or not. So this is the difference that very important for you guys to understand, that in research, which I just talked about in the last PowerPoint, that your hands-on skill is not experienced by your observer, so he cannot write. It just shows exposure, some amount of professionalism, that's it. So how are these two letters perceived? So research LOR as valued, especially for programs that emphasize academic medicine. As Dr. Katula said, the top academic medicine will not take you, leave it on top. Nowadays, even the smallest community program cannot take you, because if you have the same USMLE 2 score, you are coming from India, another boy or girl is doing the same, then how do I know who to take? Now I have to take somebody. So if I have somebody coming from Germany, and nowadays, even German, French people have learned English, and they're pretty good in English, because everybody wants to come to America. So if they have more paper, more research, I'm going to take them, because America doesn't discern from which country you're coming from. America wants to see if you're appropriate to be in the American medical system. So research LOR is important, because these are the things that they try to find out through your research LOR, which your observership LOR cannot give you. So if we summarize, number one, 2022 till 2022 primary screening school tool was USMLE 1. And most Indian medical graduate did extremely good. Why? Because in India, these things are taught a lot. You remember USMLE 1 has basic sciences, pathology, pharmacology, preventive and social medicine. And most of American graduates do poorly in that, including American graduates from some of the top academic schools, top Ivy schools. And that's why they decided to take off marks for step 1. So step 1 has just become pass and fail. So now what has happened is, most of foreign medical graduates, include you guys from India, are at a loss, because where you could score and you could bang on, come in for interview and get a seat, you now cannot, because your super strength in the field was completely obliterated by one decision, that is they blocked type 1 USMLE 1 score. So now USMLE 2 scores are important, but USMLE 2 scores only played a role maybe in 22, 23 onward it was found. And I don't know why. It's maybe because Indians are studying very hard, whatever could be the reason, but almost 76 percentile of people get more than 50%, may get more than 250 marks. So unfortunately, even CK2 has stopped being an important metric to decide who from India I should take and who from India I should not take, because your clinical, as I said, your clinical life is totally a black box, unlike an American graduate whose everything is like a crystal clear lens. I can see their whole clinical career, but I cannot see the clinical career of somebody who passed medicine from India. But the only metric that I had was step 2, and now I have like maybe 40 people from India applied for a program, and all the 40 have more than 260. Then how do I choose? Next important thing is that holistic review had very little role, because by step 1 and step 2, I could decide who to take, who not to take. Rare cases had to look for research. But in the last 4 or 5 years, research has got so important that without research, you're just not going to get in. Period. No question asked, you're not going to get in. School reputation has got important, but there's a caveat in that. Which school reputation am I talking about? American school reputation. If you're coming from Stanford and from a local university, you will be taken because you're coming from Stanford. You may be coming from the best medical school in India, but who cares? Because American program directors have no idea what is the best medical school in India, what is the best medical school in Germany, or for Egypt, or for Libya, or for Jordan. So they don't care. So school reputation is important for American graduates, not for you. You may be coming from the world's best school in India or the worst school in India. They don't care. As long as your core is WHO recognized, you are in. They don't care. So school reputation, that point is only important for American graduate, not for most of you. Now, application to seat ratio is important, because I wanted to show this site. I know not many foreign graduates do not apply for these specialties, because these specialties are highly competitive. But this just shows in the last match, that is 24-25 match, how many papers you needed to match in this. And again, this is not for foreign medical graduate, this is for the American graduates. So on an average, you needed to have 25, 26 papers for dermatology, little more than that for orthopedics, urology, almost, you can see the numbers, it's mind-boggling. And that's how people who have matched in this subject had. Again, these are not my statistics, these are all for NRMP, and I'll show you some more. So why is LOR important, and how does LOR is a clinical bystander that actually shows you how good you are as a clinician? Why does America consider research so important when it does not know how your clinical career is? Because as I said, you've seen the structure of the DNA, the two strands intermingle with each other. Same happens with research and clinical medicine in America. They are intermingled with each other closely. So research is actually a mirror of your clinical competence, because I take you, you turn out to be clinically incompetent, then I'll throw you out, which is not a big problem. You can be thrown out of the residency anytime. You can be thrown out, but that is not easy for me too, or the program director too. Why? Because the program director will have a lot of trouble trying to fill in again from another place. And what is the guarantee that the second person is going to be good? Not only that, then the whole program will come under microscope. Who did you choose? Did you choose an inappropriate person? How come your seats are emptying and people are leaving, or you're throwing out people? So they will come. And don't forget, just like you can be put on probation if you don't behave properly during your residency, they can also, the entire program has been on probation, including top universities have been on probation if they don't behave properly. So if you think, oh, it's all my loss, no. Even the program, it has a loss. There are people who have lost their program directorship because of this. So programs are very careful. There's no nepotism. They have to be very careful by well-defined rules who they take, who do not take. So let's understand why research demonstrates clinical competence also. Number one, engaging in research shows that you are invested in advancing medical knowledge. Every day a new trial comes in. You're seeing a diabetic patient. You need to know what does the SUMMIT trial or the SURMOUNT trial say, because these diseases decrease cardiovascular hospitalization by 40%. If you, rounding in medicine, do not know about this, then it's a problem. So if you are doing research, they know that you have invested in advancing knowledge, and you'll keep yourself invested. You'll keep your knowledge updated. You're not just filling up a seat, just the basic requirement. It also shows genuine passion and intellectual curiosity. Okay, I don't know the answer to this question. Let me do a research. Let me do a meta-analysis to find out if this is true or if this is not true. And that's very important also, because research is of different grades. And that's why you will have, you can Google research pyramid and you'll see the grade. The topmost research known to mankind is network meta-analysis. Most people who work with me work with network meta-analysis, because that answers important questions. For example, we did a meta-analysis in 2017, published in the Journal of American College of Cardiology. At that time, American College of Cardiology was the second topmost journal in the world among cardiology journals. Circulation was first, but then it became the world's first topmost cardiovascular journal. So we published one article about something called a subcutaneous ICD, because we did not know what subcutaneous ICD was all about. In 1 month, all the top clinical bodies in the world, American Heart Association, American College of Cardiology, European Society of Cardiology, European Heart Association, everybody changed their guidelines about that particular device. That's the power of a network meta-analysis. You have one good network meta-analysis, you're done. You will be in. You will be at least interviewed. Even if you're not matched, you will be interviewed. And of course, we publish in some of the best journals, so we'll talk about that. So number one, it demonstrates clinical competence to medicine. And this is the result in front of you. This is the 24-25 match from NRMP, and see the number of papers people had. Again, American graduate. For family medicine, on an average, they had 4.2 papers. For internal medicine, they had 7 to 8 papers. For neurology, they had 8.8 papers. For plastic surgery, they had 34.7 papers. Neurosurgery, 37.4. It's extremely difficult. That's why to get into these specialties, being a foreign medical graduates. Do they get in? Yes, there are people who spend years doing research so that they can get that amount of paper and then get in. Or after doing general surgery, they join research programs to get that amount of paper, and they go into these dermatology, 27 papers, obs gynae, 9 papers. So this is from the NRMP side. So by now, it must be very clear to you that without research, this demonstrates clinical skills. You are not going to get in. They're not even going to call you for an interview. Second thing is research shows you the competitive edge. With many applicants having similar clinical background, just like you guys have, they're all from India. I don't know their clinical background. It's a complete black box, but somebody has a lot of research. Of course, you are better than the other. So you are obviously more competitive. And these are actual papers that has been published to show what I'm saying is true. As I said, these are not my assumptions, my thought process. Everything that happens in America is institutionalized, is protocolized, and this protocol comes from actual clinical research. So people have gone through this and showed its competence, and that's why clinical program directors are forced to follow this. Number 3, it shows clinical skills. Research highlights your critical thinking, your problem solving, and your analytical abilities, traits that are highly valued by program directors. Why? Because these are exactly what you need to do when you do clinical medicine. You have a patient in your emergency department, you go to see the patient has cough, he's having difficulty in breathing, his legs are swelled. Does he have COPD or does he have heart failure? You don't know. So it is problem solving all your life. So somebody has COPD and somebody has heart failure, the treatment is totally different. Then you do a BNP and find out that his BNP is 200. So what do you think he has? He obviously doesn't have heart failure. He has COPD. That's your analytical ability. But I have no clue what your analytical ability is as a program director, because your entire clinical life is a black box to me. But if you have done research, it shows that you have critical thinking, you have the problem solving attitude, and you have analytical skills. And those are the things we write in our paper, based on your performance. I at least write that based on the fellows who work with me, because that's what the program director sees. And that's what happens also. If I show you videos of my, if I get you to talk to people, they'll tell you, they ask them in their interviews, what did you work with Dr. Basu? How come you chose this topic? Because you have to understand, most of the interviews takes 2 minutes. You're kicked out before you even get it, because they don't have time to waste time with those 80 people that they are calling. They want to talk and chat with you if they think you're important. How do they decide that? Not because of which country you come from, not because of how good your face looks. It is exclusively based on your CV. You look at this, they look at your CV, they look at your CS2 score, they see you have a bunch of good publication, you are in. And then they start chatting with you, because they don't have time to chat with you. As I said, most of the program directors are extremely busy people. They'll only chat with you if you're valuable to them. You get valuable to them when you have a good CV. So then they'll start talking to you. How come you chose this topic? Because they want to get more out of you. They want to elicit, how is your critical thinking? How is your problem solving? So a lot of people who I mentor, I actually teach them how to, because I've been doing this for 25 years as a program director in internal medicine, then cardiology. Now, sometimes I do cardiology, but I always do EP. So I know exactly what questions are asked. And in America, the questions that are asked are pretty fixed. They can't ask you, oh, if you're a lady, I can't ask you, are you planning to get pregnant when you're in fellowship and take 3 months off? I can't ask you that question. That is a banned question. So most of us who have been in the program, who have taken students, know what questions are asked. And that's why my students have come back and asked me, Dr. Basure, did you call up the program director? I said, why? Were you asking me this question? Because he asked me the same question that you told me they will ask me. Yes, because there are only a fixed amount of questions they can ask you. And we know the trend, and we've been doing that for 25 years. And this is exactly what they need to ask you. And that's what they will ask you through your program when you appear for the interview. So how does research activity show what critical thinking you have? Number 1 is your questioning, your analytical reasoning. Does he have COPD? Does he have heart failure? There can be a bunch of reasons for heart failure. You pick up Hurler's and Hunter syndrome, which might cause 1 in a million. and that's your main diagnosis, then you're gone. The program director knows that this guy is completely useless. This guy has got no practical knowledge. So analytical reasoning is very objective judgment. Okay, this is what his objective judgment is. His BNP, I'm not very sure. Maybe his BNP is 400, could be heart failure, could be COPD, not 10,000, then it's only heart failure. So let's take an objective judgment, because you're God, you're not God, you're just a physician. You can go based on science. But do you know the science? How do the program director knows that you know the science? Based on your research, that, okay, this guy has done such important papers, so he must be having a good clinical knowledge. That's how they do. Your problem solving, is it COPD? Is it heart failure? Is it something else? What is your logical thinking? End of your logical thinking, you may be completely wrong. That's done. Today, after 25 years of medical practice, me and Dr. Katula, we can't say that every 100% patient we get the right diagnosis the first time. We can't. Then we have to be God. We cannot be a physician. But 100% of the time, we have a logical thinking. Your logical thinking may lead to a wrong diagnosis. That is completely excusable. Your program director must have done that 100 times. Come to a wrong diagnosis, because diagnosis slowly gets evolved. But your thinking cannot be illogical, and you cannot have a logical thinking until you can design experiments in a research. That's why it's important to have research activity. Interpreting result, how are you collaborating with peers? In a research, you have 15 people doing the research. Do you collaborate well with them, or you fight with them? Because then you'll be fighting with your other residents when you're in a stressful situation, like in a clinical practice. And then that's going to be a big problem. Last is networking and mentorship and publication and presentation opportunity. When you do this, you get to know more people. Maybe the guy, like this is a paper on that too, that when you publish, a lot of the program directors and a lot of the people in academic medicine, including me, we go to a bunch of conferences. So when we go to a bunch of conference, either we are invited to give a talk, or we just go there because we want to see what is going on, what are the latest research. So you might end up meeting your future program director. He'll not come and tell me, hey, I'm the program director of medicine there, or I'm the program director of XYZ there. No, he's just going to come as a meek guy who just wants to know what your research is. He's very interested. So you go and explain to him. He will know, oh, this guy looks interesting. So next time, maybe when you apply, you network, he will try to take you because he has physically seen your capacity. This is an important paper, and I just showed you to show what exactly this actual original research paper, which shows that in orthopedic surgery, a foreign medical graduate has to have 3 to 5 times more publication than MD seniors from the US. That's not why I showed you this, because there are very few people who actually apply for orthopedics from outside, and it is extremely competitive. The reason I showed you this is the next one. IMGs should recognize the importance of higher publication numbers in the matching process, as well as the states with high IMG matching rate. So not only should try states with high IMG matching rate, but you must have higher number of publications than your American cohorts, whose I have shown you the number of researchers they have. So take that for granted, work for that now before your next match, so that your next match can be a guaranteed entrance to American medicine. This is from NRMP again, the latest match. It clearly shows how many papers an American graduate who matched and who did not match. So blue is matched, sort of teal green is not matched. As you can see that a lot of most places, for example, diagnostic radiology, twice the number of papers for people who have matched. For neurosurgery, almost 10 papers more for those who have matched versus those who have not matched. And say plastic surgery, as you see, there is less for people who have matched. Why? That's where recognition comes. If you're from Stanford, you're from Harvard, you're from Yale, they do get favored. Whether it's fair or not, I don't know, but that's the truth, because people think these places do a good job teaching their medical residents. In fact, in Harvard, most people do what is called MD PhDs, and they have tons and tons of research papers. So obviously, it's not really biased. Obviously, when they come out from this medical school, they get a preference invariably. So residency program directors, what is the program director's view? This is a bit of an old paper. This is just 2022 paper. So the scenario has changed now. This paper says 41% of residency program directors believe research participation is becoming more important in deciding whom to invite for interviews. This is a 22 research paper. Today, I think the number has gone to 100%. In 22, when they just stopped USMLE 1 for the first time, they did not know what the scenarios will be. Even at that time, residency program directors, majority thought it's important to have research participation. Today, it's not a majority, it's a must. 100% want you to have research, otherwise they're not even going to invite you. So it's important to also understand that what is their view of directors see research as evidence of intellectual curiosity, self-directed learning. Very, very important point. Why is that? You're not a school child who has to be fed. You're not even a graduate because you've already done a medical graduation. You have to have self-directed learning. If you are not updated with the latest trials, then you're a useless fellow for me. I'm going to kick you out because you're going to mistreat my patients. So if you do not have self-directed learning, then it's a big problem, because whether you're in Harvard, Yale, or Stanford, or whether you're in smallest medical school, nobody is going to feed you anymore, because at that period of time, it is expected that you feed yourself, you increase your learning yourself. And research shows that. So that's why research is so important. It shows you intellectual curiosity. It shows that you have self-directed learning. And more importantly, your ability to handle complex tasks. Clinical medicine in America is an extremely complex task. Seeing the patient, talking to the patient, elucidating the right history, combining the right history with your latest updated knowledge from the journals, making sure you're having the right treatment, making sure you're ordering the right test, making sure you're giving the patient the right treatment, and following up the treatment on a regular basis to make sure that he's cured of his ailment. Each of this is a complex task. If you cannot handle one good research paper, then you are incompetent in all of these. So that's what the thought process is. And more importantly, teamwork. They want you to be a team worker. If you work with 15 people to come out with a publication, nobody's better than you. You are collaborative. You are ready to work with others to get your work done. If you are not, then I have a big problem taking you in my program. That's what the program director thinks, that I cannot take this guy reliably because I do not know how he'll behave when he's meeting with other people. So as part of multidisciplinary clinical team, your success will depend only on how your research publication is. So this is another program. This is also a little old. There are also views. This is a national survey of competitive which clearly shows that when post USMLE, a huge number of people, the only point that they see is your research. If your research is good, you're in. If your research is not good, not in. Now, where do we publish? We always should be publishing in PubMed-worthy publication. They must be peer-reviewed. And why is that? Because you have to avoid journals with no peer review or fake impact factors. Why is that important? Because of something called as predatory journals. What is predatory journals? Go type that in Wikipedia and find out. There are hundreds of journals. I've got a girl coming and telling me, sir, I've got 20 20 case reports in one particular journal. I don't want to name the journal. So then I told her that go and check that journal and find out what that journal is. And then she came and found out that journal is actually a predatory journal. So predatory journal, in short, is a journal that takes money to publish. They have no good peer-reviewed process, so they are banned or blacklisted in America. If you have a publication, don't bother showing it in your CV. If you do not have a publication, try hard not to have another one in that, because your money will be wasted. There are many such journals which are known to people, but which are, it's easy to know. I mean, it's not difficult for you to know if it's predatory or not. Just go type the name of the journal in Google or in ChatGPT or in Perplexity, in any of the AI models, and it'll tell you that this is a predatory journal, so avoid it. Some journals are on the borderline, that's okay. We don't even publish those. When I publish only in top journals. The other option that is publishing in journals is extremely costly. That's why it comes with a cost. It's not free, because each journal charges you, for example, Frontier charges you up to $8,000 for one publication. Most clinical publication in Frontier cost around $4,000 to $4,500. All the other top journals, I'll show you a couple of them, it's between 4,000. So you have to pay the money. Why? The reason we have to pay this money is because if you do not do, they will not make it open access. Now, why open access? Open access is because you can show it to everybody. You can show it to your program director before the match that, listen, I have got a publication and this is the publication that came out. Your program director in obs and gynecology doesn't expect you to have a publication in obs and gynecology. That's another question I'm very often asked. I'm trying to apply for pathology. Should I have publication in pathology? No. Why? Because remember, they are not taking you as a pathologist, let alone they're taking you as a professor of pathology. They are just taking you as a student. So they want you to have a publication. Doesn't matter which subject. Why? Because the research methodology in obs gynae is same as pathology, is same as neuroscience, is same as vascular medicine, is same as neurosurgery. 2000 years with 100 Nobel Prizes, research is same. Topic can be different, methodology is same. Network meta-analysis discovered maybe around a decade back, more than 1,000 papers on network meta-analysis in 1,000 different subjects. Method is only one. You can just see one video or take one course and you learn that. It doesn't matter what the subject is. So you don't need to have different subjects, your particular subject research, any subject will do. But suppose if your program is medicine, he may not have access to other places. So when you have an open access, one advantage is that A, you can send it to him and he can open up and see what research you did. B, you get more downloads, you get more citations, and citations helps you later on to get a job as a professor or in an academic situation. This is Journal of American Heart Association. It's possibly the lowest grade journal among the 4 or 5 journals that American Heart Association has. Despite that, the article rate is $4,000. So what we generally do is we divide that between 10 students. So we charge a particular amount and we divide that among students so that it doesn't go like if you published by yourself, you would have paid $4,000. But don't forget, not only you, there are professors in multiple countries who haven't had a single publication. Their publication was not thought worth enough to publish here, though we publish here being in the US and having understood the training of publication, what is needed to publish in top journals. So even if you had that money, you wouldn't be able to publish in there. And of course, many people cannot afford. So that's how we get a bunch of people working together. And plus, we also teach them how to do research. So they learn how to do research so that they don't have to be dependent on anybody in the future. They can publish of their own without being dependent on anybody. This is one of the journals where we have to pay almost $3,500 current publication in cardiology. We just did this. And the names that you see here, they are from Egypt, they are from Saudi Arabia, they are from India. And you can see Dr. Garg's name here also. They're all students. 90% of them are students from India, Nandini, Abhishek, Anit, Urvesh. Urvesh has got 14 interviews. This is the first research paper he ever did. And despite that, he got 14 interviews, which many Americans don't get. And he got interviews into academic places. And he joined an academic place finally, because he got multiple interviews in top academic places. And in every interview, they asked him. If I had time, I could have shown his video. They actually asked him that, how did you work with Dr. Basu? How did you get to this topic? Why do you think they're asking him and not other people? Because they want to take him. So they want to know exactly, did he do the study? And that's why when I mentor or when we mentor, what we do is we make you actually work on the paper. So you understand the paper, how you go there. This is not a fraud that you pay somebody money and he creates a paper and sends it in your name. That's a fraud. Nobody does that. You have to work on your paper, and at the site we do help. After you work on your paper, at the end of say, generally we take 12 weeks to teach you guys research. Once you learn research in 12 weeks, in that 12 weeks, we handhold you and help you publish. Every stage we handhold to make you publish. And so at the end of 12 weeks, you have a paper ready. But is that paper good enough to publish in a top journal? No. I mean, if I was given a chance, I couldn't be an Einstein in 3 months. No, 12 weeks is 3 months. I don't expect you guys to be with absolutely no research experience. Then we work on the paper to make it better. But these papers are still done by you. You work with the faculty on those papers. And once the paper is ready, we publish it. And that's the result. You get people called in their interview. They get interviews. And of course, Uvesh and other people matched. So summary, USMLE is not more competitive. It looks more competitive because there are more competition, but the actual competition is same. People get in if you know the trick. The trick is research. Get research papers, you're in. It doesn't matter which place, which country, how you look, or anything else. What's your score? Because unfortunately, score has stopped being important. Even USMLE2 scored. If you do not have 250 in USMLE2, it's more difficult. You need to have more research papers. But that's also not a complete no-no. But try to get more than 250 in USMLE2 and get research. You'll just flow through because that's what the guys they need. Research quality, very important. There are people who have one research quality. I mean, you get a one research in Nature or Cell, which I don't publish in those papers because I'm not a molecular scientist, I'm a clinician. So I'm not expecting any of you will publish in Nature where Nobel laureates publish. But if you do publish in Nature, there are a lot of people who, after doing PhDs in America, decide they want to go into medicine. That's fine. In America, there's no age. At 76, there was a guy who went into medicine. So 45, there are many who go into medicine 45 after doing their PhD postdoc. They one fine morning, they want to be a doctor. They have a Nature paper. Where do you think they'll go? Straight to Harvard or Stanford. Nobody will even ask them a question. So quality is important. So getting predatory journal is a negative marker, but getting in some of the top journals is a positive marker. Even one paper might get you in, like what it did for a lot of our students who worked last couple of months. Open access amplifies visibility, but it comes at a price. It's very costly. So generally what we do is we divide it among students so that it doesn't hit you that hard. But still it's a win-win situation because if you had done it by yourself, you would have paid $2,000 more plus 9.9.9. I don't know how many nines after the point, chance that you'll never ever publish in this sort of a journal because, as I said, there are top professors in multiple countries, including India, including top professors in top Indian institutes like PGI, AIMS, who have never published a single paper in these top journals because the publishing strategy is totally different in this country. I did my DM in India. I did India's ultimate degree, DM, and I did in one of the top places in India. But it doesn't matter because I didn't get to do much of research. So it's a different lifestyle there, different lifestyle here, and you learn it, not big deal. So the strategy is publish. Once you publish, you are in, nobody can stop you. Okay, guys, I'll stop my share and I'll hand over to Dr. Garg.
Thank you very much, sir, for that insightful talk. And I'm sure many of us enjoyed listening to you and, got a lot out of your talk. Now, if anyone has any questions, you can just put in the chat box. And if you have any queries, anything, you can just put it here and we'll answer you.
So one comment, Dr. Basu, that was
Yeah.
a presentation. People who have done research, but they are not yet published. If they did not publish their paper yet, but they still can write that in their resume, publication pending.
Absolutely.
And then when they go for the interview, they will ask you. So you have to be prepared to answer the questions. It's not whether you're first author, second author, third author, or whichever. But
doesn't matter.
Explain the project is very important, as Dr. Bassler mentioned. So you don't have to necessarily complete the project, but at least if you say that you're working on something, that'd be good. So ideally you have to complete the project, publish it and all that, but sometimes it might take longer than you expect. And in that case, you can just say publication pending, and then you explain when you go for the interview. Yeah. Thank you.
That's a very important point that you brought out, Dr. Katula. I actually have to tell you this. The last article that I showed you guys, that was not published before the match. He wrote in that this was in the process. That itself spurred question. The program directors asked him, why did you work with this project? What was the reason? How did you choose this topic? What did Dr. Basure teach you? The board is not published. And that's what I tell people all the time, as you exactly said, Dr. Katula, is The program directors have gone through the process. They understand it takes 6 months to publish. It's not that easy. Today you write up a paper, tomorrow it doesn't get published. It takes 6 months. Some paper circulation takes almost a year to publish a paper. JAC takes almost a year. But as exactly Dr. Katula said, even if you say that this project you worked in and they like that project, they are going to talk to you about the project. As I said, most of the student who got selected this match did not actually have a published paper, exactly as Dr. Katula said. The matching was in March. This paper, if I'm not mistaken, was published in April or May. But he just put it in his CV that I worked with this paper, and they asked him questions like, why did you choose this topic? And you have to obviously give brilliant answer. He just said that the drugs that we use for bringing down obesity cost you $2,000 a month, and 200 million people in America cannot afford those drugs. Plus, those drugs come with a side effect. They decrease your lean mass, so that can affect your aging also. So that's why I worked on this to see, does yoga play a role? I mean, you can't even believe, like Tulane, UMS, VCF, so many academic places matched him. And he finally got matched. So they are looking for this kind of type of kids who has out of the box thinking. That's all they need. They don't want you to be a Nobel laureate. They themselves are not Nobel laureates. So how do you expect you to be a Nobel laureate? But since they do not have your clinical background, they need to know a little more, at least through your research, that you do get to have all those characteristics they're looking for. But thanks for pointing that out, Dr. Katula. That's that's a very appropriate point.
Yeah, we have one, two comments here, sir. Dharam Varun Kumar says, I finished my USMLE steps and came across large data research on YouTube. I also learned SAS in India. Any suggestions on how to refine your research skills by doing online courses, and also any suggestions to get the research position in the US?
Okay. So research positions, let me make it very clear. I think Dr. Katula did say about this. There are hundreds of research positions in US, but they are not for you and me. Again, I'm repeating that. There are hundreds of research positions in US, they are not for you and me. Why? America takes people, they want people to help them in their research. Who does it take? It takes PhDs trying to do postdocs. It does not take clinician. Very simple reason. Can you do Western blot? Can you do Southern blot? Can you do you cannot, because we are not taught that in clinical medicine. So they want a person who can do these. So if you're a PhD postdoc, you'll get. Otherwise, starting a research position is next to zero. Second love. People try to join MCH and they believe that if I do clinic community health, then maybe I'll do research. No, you won't. Why? Program directors are looking for research papers. The 2 years you spend, you may end up doing a paper, you may not end up doing a paper. So that 2 years is not only wasted, that 2 years is also lost. So that's very important, because remember, every year, last year 23,000, this year 50,000 applications. So losing 2 years is a big loss. You may be completely lost in your career. So trying to get a free research position or even a paid research position is 0%, not even one. I've never heard in my 25 years a medical doctor getting a paid research position in America. Yes, if you are a PhD, you're wanting to do postdoc, they want a lot of postdocs and they will give you a pay to get you a position there. But even that, most people look for MS PhD so that they can make you work as a PhD and then take you as a postdoc. So no way to get research positions in America. There are people who join me and we'll share some of the numbers. Kawana Nirmal's number is there. We do take a few students and help them. I cannot take a lot, but so connect with them. We'll show you what we can do and what we can take. But basically what I do, and now we have sort of protocolized it, is we teach you guys 3 months of research, which is 12 weeks of research, where you actually learn research, how to write a systemic review, how to write a meta-analysis, how to write network meta-analysis, so that you are really a physician scientist as you're expected in America. Why do we do that? For different reasons. First of all, the lowest marks are got in USMLE by people who fail in biostatistics, most Indian do extremely poorly in biostatistics because they are not taught biostatistics in medical school. I was not taught in my medical school, despite doing MBBS, then I did my MD, then I did my DM in cardiology. Despite that, I was not taught. So I came to this country and learned it. So once you do biostatistics that you learn from the course, you start doing great marks in USMLE 2, which is very important. Second thing is that once you join residency, within first couple of months, you will be called to present in a journal club. You will be asked to present in a journal club. If you cannot read an article, you think it's easy. It's not. Open up a New England Journal of Medicine article and try reading it. Half of the statistics will go above your head. What is a KM curve? What does that KM curve mean? So you have to understand each of these meaning, and that will also help you in your residency once you do this course. Third is, just like I have been self-taught, I want you guys to be able to be researchers in your own way. And there's no reason why you should have a mentor at every stage. Once you learn it, you'll be a mentor. So we have a 13, we like in 12 weeks, we teach you guys. And in that period, we actually make you write up the paper so that you are actually part of the paper. So when Urvesh or other people was asked, they could easily say, yeah, I wrote this paper, I went to Embase and I searched it, I couldn't get this, then I went to Cochrane, because they've been through the path. Because we don't do any fraud here. We don't publish for you. I can charge you $10,000 and I'll publish for you, but that's a fraud. We don't do that. I want you to be part of the research, because today I might publish for you. What happens tomorrow when you become when you're taken into residency and you try to get into, say, oncology, which is extremely competitive nowadays, because these guys make a ton of money. I don't know about Dr. Katula, maybe he also makes a ton of money, but most people make a ton of money. So it has become a hot specialty. You're not going to get into that unless you have a couple of research, good papers in that. So long story short, no chance of getting a research position in America, either free or paid. For us, yeah, if you're a PhD wanting to do a postdoc, yes, there are tons of position. Almost every Stanford, Harvard, all the universities, all the program leaders advertise for that, but nothing for us.
Thank you, sir. We have another question asking, does program directors care about topics emphasizing on AI impacts in a particular field?
Oh, absolutely. AI is very hot, but the problem is there's difference between being a hot in YouTube and being a hot in actual practice, because the actual definition of AI in medicine is still being worked out. Uh, the way AI works, because I'm very much interested in AI, has been till now restricted not into hardcore clinical medicine. It is more into imaging. For example, you read a EKG. If you cannot read the EKG, the AI will read for you. If there's a radiologist trying to find out a CT scan to see if there's a small nodule, it is cancer or not, he might take half an hour. The AI might do that in 5 minutes. So AI is hot, but AI can be used. If you have papers in AI, that will be good. Not that it's not good. Any paper is good. Basically, they want you to have research skills. That's the short note, the short part of it.
Right. Uh, Satish says that there are a lot of epidemiology research positions. Not every research position is a basic lab position. I worked as a research staff post MBBS after training in epidemiology. He did his MPH. And if you have training in SAS, there are a lot of SAS programming analyst jobs available. But that should not be your primary goal. Well, that is more about the research positions, not really.
Yeah,
Uh,
exactly. So those have nothing to do with clinician.
yeah.
Clinician, you do a short course, you learn, you get a mentor, learn under him, publish with the help of him, and then you become your publisher by yourself. You can start publishing of your own, but that one or two publication that you get done should get you into residency.
Right. We have one more question. Do certain types of research carry more weight, and do case reports, smaller publications strengthen applications, or is it better to do a larger project?
Yeah, yeah. So, well, I don't know if case reports does, but technically for research-wise, case reports is the lowest in the rung. If you look up the research pyramid, you can see the case reports are lowest. And with the advent of predatory journals, every Tom, Dick, and Harry publishes a ton of case reports. So they have value is next to zero now. Does it strengthen your CV? Maybe it does. I don't know. But but certainly case report won't get you a position or even an interview. That's for sure.
Right. Vraj asked, what does the sequence of authorship signify as POV in PD perspectives?
Zero, no significance, because they know that you're part of the research. That's all that is important.
Right. Are meta-analysis helpful in building your CV?
Oh, absolutely. Meta-analysis is the highest. Go and find out the research ladder. If you see, the highest research is network meta-analysis. Then second to that is systemic review with meta-analysis. Third is randomized clinical trials. Now you cannot do randomized clinical trials. You need thousands of dollars, multi-institutions to do that. So for an individual person, the best is doing network meta-analysis, which we do for our students as well as for us. We all work together. So that's yes. So meta-analysis, in short, is very, very important. But with thousands of meta-analysis already coming, importance has decreased. Now the most important is network meta-analysis, which is even newer, even more complex, takes more time, and gives better answers.
Right, sir. I think that the last question is, what is the best way to get involved now?
So best way is
So,
just talk with, just directly
Kavana.
mail them Kawana, give your numbers, Kavan Nirmal, and they can connect, and then we can talk and then take it from there. If they have any questions, we can talk and take it from there. But basically, it's just get involved, and with the process, you learn how to do research, and at the same time you work to get your first paper out. And then, so earlier you join, if somebody is planning to do in September, you should join immediately. Don't waste much time, because hopefully at least we'll have a paper ready to put it in your CV. Paper will not be published, but enough to get you an interview if you have it in your CV. So that's what is important. And especially if you're a new batch, you're applying for the first time, it is very, very important that don't waste your chances, because once you applied, then you become an older batch, then you're taken in a different category. So if you are a new batch or you're applying for the first time, make sure that you try your best to get your best out there, and not miss an opportunity, wasting money, but not getting any calls.
Right. So thank you very much. If you have any future questions, feel free to ask and get in
I
touch with
think
Kavana. Well,
there's
I'm
one more, I think. Is there one more questions?
uh, can we
Raj
add
Rangaraj, can we add
yes,
abstract journal? What is?
can we add abstract journal publications in our application, but the full text is not published?
Absolutely.
Yes, you can. Okay.
Okay.
Anish, there is one more question, sir. They have sent twice, so let me just clear this up. Thank you for arranging such a great session. I am a non-US IMG, cleared all USMLE steps and will apply for match this year. I'm working on various research projects like Meta and CDC along with poster presentation at US conferences. My question is how to seek opportunities and collaborate with USMDs for research. I'm highly to work with you, Dr. Basure. Please share your email so I can request you to collaborate and send my resume. You can just send a resume to Kavana and Nirmal, and we'll just get back to you. For
Or
sure.
Kavan and Nirmal, make sure you just text them your email and everything so that everybody
Yes,
gets ready.
the number is in the chat box. If you want to like us to contact you, you can share your number as well in my
Yeah.
personal DM. I'll just make sure I
Yeah. Share
contact.
your number. We'll connect with you also.
Okay. Karthik asks, sir, does step 3 completion helps in matching?
No, it does not, because in matching, it is not counted. The only reason I always ask people to do step 3 also when you are a foreign medical graduate is that you are completing your steps. Then the program director knows that what happens is that most Americans don't give step 3 before matching. They give it in their second year. But for an Indian graduate, I ask them to give only reason because suppose you get step 2, then you fail step 3, then your program director is in a problem because you cannot ever become a doctor in America without passing step 3. So they tend to, not always, but sometimes they tend to see if this guy, I mean, if you have a bunch of research and everything else is good, then don't bother. You will get it. But if everything else is not good, then I think it's better to do step 3. But does step 3 directly play a role? Absolutely not. Absolutely not. Not even 1% role. And you're not expected to have your step 3 before your matching.
Okay.
Is that all we are done? Over to you, Dr. Katula.
Oh, thank you, Dr. Basu. That was a very informative session. So thank you for your time and helping all the IMGs. So we'll continue to do this. And if you have any questions, you can always email us. And we have some email addresses there and phone numbers. You can email or call Aditi if you have any questions about the research. And that will be communicated to Dr. Basure. And he has wealth of experience, as we have heard just now. And yeah, definitely to learn research is very important, not just publication, but also the process, the procedure, the statistics, and everything. So people, I know when they interview, they know how much they want to know how much you know about the research, because that's what makes us better physicians. So please, feel free to ask us any questions if you have any. After this webinar is over, we'll have this available, the recording on RP website, so you can visit RP website. If you want to, hear this again. Also, tell your friends to do that as well. So, thank you, Dr. Basure. Thank you, Aditi, for today's webinar. So we all have a wonderful day.
Thank you, sir. Thank you very much.
Thank you.
Bye for now.